Carolyn Clancy, and I wanted to make sure that we got her title exactly right. She's the Interim Undersecretary for Health at the Veterans Health Administration. She's been doing that for some time. She's had a long, illustrious history at ARC and in public prior to coming to the VA. And without any further ado, Dr. Clancy, over to you. Interim versus, I wanted to make sure I got it right.
All right, thank you. Well, good morning, everyone. Please ignore that person up there on the monitor, if you would. So I'm really delighted to have an opportunity today to tell you how we are transforming healthcare for veterans. I joined VA about 15 months ago because I thought it was the system in this country which had the most foundational components in place to provide what health policy experts have been thinking of as 21st century healthcare, and I still think that. And the sense of mission, one that I know that you're all very, very familiar with, is palpable across many of our employees. It's been an interesting period of time, but I am incredibly optimistic and very excited by the size of the opportunity before us. So, what I'm going to be telling you about is Bob McDonald's vision. And this is that every veteran in America comes to see the Department of Veterans Affairs as my VA. In other words, I hope you're all sitting down right now. You won't actually necessarily have to know the form name or which administration you need to be dealing with. It will all be seamless. And not only that, this will put the veteran in control of how, when, and where they wish to be served. This means that we're going to have to make some changes in our healthcare system. So for example, many of you are familiar with the fact that the Veterans Health Administration, which is the largest integrated delivery system in the country, is divided into 21 networks, which are comprised of a number of facilities, outpatient clinics, and so forth. It's huge. It turns out that if a veteran gets his or her care in one network and has the audacity to move to another one, it's actually not that easy to, say, get a refill on prescriptions if you're traveling or left your medicines at home or whatever the case may be. We are in the midst of trying to solve that problem right now. My VA will measure success by the ultimate outcome for the veteran, and it will integrate across programs and organizations. So the guiding principles, for those of you, by the way, who are having a deep terror in your heart that I'm about to show you an org chart, the kind you can't read, you can just rest easy right now, because this is very much a dynamic process which is still unfolding. But the principles, we believe, are incredibly important. Any restructuring has to be considered through the lens of the veteran. In other words, success is defined from the veteran's perspective. It has to optimize VA's unique competencies in healthcare, benefits delivery, memorial affairs, and also has to enhance external partnerships to support service delivery where we're less well postured to deliver care and services that veterans need. We do a lot of this now. It tends to be on a somewhat ad hoc, one-off basis. This will now be a much stronger focus for us. And again, a very strong focus on integration and efficient coordination, control, and information flow to improve service delivery. Let me just give you an example from real life for those of you who have not had the utter delight of intersecting with healthcare or the department anytime recently. So I had a problem recently. I was traveling and learned that someone had managed to take a picture of my ATM card and was actually making very generous withdrawals from my account before the security people shut it off, which was a good thing. So I have spent a lot of time in the past few days calling the call center. It turns out the call center for where I do banking is incredibly well equipped, very friendly people, very helpful, to answer fairly straightforward questions like, Can I move money from checking to savings, that kind of thing? Are they the same account numbers? It is actually not so well equipped to help solve problems. And of course, as I've been experiencing this and put on hold and accidentally disconnected and so forth, deep in my heart, I'm wondering, I hope our call centers don't work this way, but you better believe I'm going to be testing them. Because oftentimes what veterans report is that at every transaction, people are incredibly nice, very helpful, couldn't be more well-meaning, but they are not actually clear that they are 1 inch closer to getting their problem solved. And there will be a very strong focus on productivity and efficiency, and we need a much stronger focus on the future in terms of veteran needs and demographics. As I've been traveling around visiting a number of our facilities, I've learned there's a lot of veterans moving to Arizona and Nevada and North Carolina. We have not been able to keep pace with that demand, and clearly the future has to be much different with that. What are the criteria for success? Very much about improving veteran engagement and experience. Again, a strong focus on seamless navigation and an aspiration that every employee is well-versed in the entire suite of VA offerings. You know, Bob McDonald, our new secretary, has had a lot of town halls everywhere he goes and at central office. And I was very struck one day by an employee who raised her hand. And by the way, when people raise their hands, he is very insistent that everyone call him Bob. Which I find quite remarkable. I've had the opportunity and privilege of working for a number of secretaries of Health and Human Services, several of whom started off by saying, "Call me by my first name," and that usually went away before the first week was over. It definitely has not at VA. But in any case, one woman got up and said, "You know, I work in construction and facilities management, and yet I know enough about all the parts of VA that my name is out there. I don't know if it's in a bathroom or something, but people know where to find me, and they're almost never calling me about my day job." So it makes me think that there aren't a whole lot of people who have the same breadth of knowledge that I do. That actually needs to change. And of course, what really drives the secretary a little bit crazy is that we have so many websites. The little joke in the health administration is that we all need a SharePoint site to manage our SharePoint sites and so forth. So we will know that we're succeeding when, however a veteran chooses to engage with VA, whether that's by phone, in person, digitally, and so forth, they will experience a unified department. Clearly, this is going to be a lot of work. It doesn't happen overnight. Bob McDonald is an incredibly compelling, very positive guy. You don't command change. It's going to require a great deal of process improvements, trying to figure out why is it that it doesn't work that way now? How is it that we can make it better? And ultimately, what we hope to get to is that we're providing proactive, coordinated service delivery in real time wherever possible. So we will be reorganizing to be veteran-centric. One of the challenges that happens, certainly from the health side at VA all the time, is almost everything has to come into central office. And as the secretary has often observed, the point of integration is the secretary's office, which feels a little bit too siloed and not coordinated and sort of veteran-facing. So the concept and focus is to integrate at the lowest possible level and to simplify and standardize operations. There's a saying in the Veterans Health Administration that if you've seen one VA, ... right? You've seen one VA. Now, clearly, many of our facilities have unique, interesting characteristics of their buildings and so forth. We're not going to wipe that out. For one thing, we own them. But, you know, the idea that the experience wouldn't be very, very similar is not going to be tolerated anymore. And veterans need to know and believe in their hearts that the department is structured to meet their needs. So that will mean a great deal of focus on back-end structure and processes to support those on the front lines. Those of you who've ever had the opportunity to hear the Secretary speak or testify will know that he often uses an inverted triangle to make this point. You know, he'll show a regular triangle and say, well, this is how we often think of departments, right? And the secretary is at the top and all the people on the front lines are at the bottom. And he keeps reminding us that actually his vision is that we flip that. And the people on the front lines serving veterans, closest to their needs, they're actually at the top. The rest of us exist to remove barriers and help them do a better job. So we had a number of announcements on Veterans Day. One of them is that we will be creating a new customer service organization. I believe that if we can do this right, we will not only make things better for veterans, which is our first and fundamental focus, but also we can help restore people's trust in government. We will be consolidating into a single regional framework for all administrations, all while not disrupting what works well operationally in benefits, healthcare, and so forth. And we're hoping to create a national network of community veteran advisory councils. The really wonderful thing about the opportunity to serve veterans is that you have so many partners out there. And in San Diego right now and in some other places, these partners regularly meet together. My colleague, Linda Schwartz, who's with me today and sitting down front, you should wave, Linda, so people know who you are, joined us recently as the new Assistant Secretary of the Department for Policy and Planning. And she brings a very real-world perspective from having served as the lead for Veterans Affairs in the state of Connecticut. The last thing we'd want to be doing in terms of trying to meet veterans' needs is to leave people like Linda and her colleagues out of it. So the San Diego Advisory Council has a huge array of stakeholders who meet on a regular basis trying to figure out how can we do a better job by veterans. And we will also be taking a very hard look at how we can align our internal business processes in a more efficient way. So in addition, there will be a Center for Veteran Engagement that will set and monitor performance standards for customer services, provide training, and so forth. You know, as I've been reflecting on my own experience with a call center in the past few days, courtesy, unquestionable. Knowledge and the ability to help solve problems, not so much. So that all has to be part of the mix. We're also going to be launching performance improvement teams, helping facilities increase performance, getting the right metrics for success. Some of you who are thinking about, well, wait a minute, how are they going to measure customer experience in healthcare? Depending what time you ask people how they're doing, you could get very different answers, right? If you have a successful operation and ask people how they're doing the following day, oh, I'm sure they'll tell you. It may not sound so positive. And the truth is that you need a variety of metrics to be able to do that. You need almost real-time information to know how well you're doing, for example, with pain management. But you need sort of longer term to know how did all my services fit together. All of that will be part of it. And again, I mentioned strategic partnerships. Now, shifting gears specifically to the health system, the three pillars of our road to Veterans Day were pretty straightforward. One was improving customer experience. A second was improving performance. And a third was setting the stage for long-term excellence. I told you a few minutes ago that I came to join VA very, very excited about the potential, and I still am. But this blueprint really pulls it all together into a very practical roadmap so that we're not just excellent at most of our facilities or many of them, but that timely access to high-quality care is the default option wherever a veteran seeks our assistance. The blueprint calls for a major transformation as well, focused on the veteran, and aligns with the goals from our existing strategic plans, which, by the way, are wonderful. I mean, they would bring tears to your eyes. The challenge has been that they're a little bit blue sky and not quite so embedded in the fabric of people's jobs. That's really what the blueprint is about. And the blueprint organizes 10 strategies under 4 themes. The first is improving performance. The second is promoting a positive culture of service. I'm sure you're hearing the alignment here. A third is advancing healthcare innovation for veterans and the country. You know, we were extraordinarily excited this year that 2 of our researchers were Service to America Medal winners for their work on the medical consequences of spinal cord injury. Now, first of all, meeting those people was just a total rush, an hour of excitement for me. Because they remain very excited and curious about how they can do a better job. They've made discoveries that it's highly unlikely that anyone else would have invested in, right? And at the same time, though, that information doesn't just benefit veterans, it benefits anyone who's had a spinal cord injury. And the last, of course, is improving operational effectiveness and accountability. So just to walk through these relatively quickly, we are now, thanks to the new law, in the midst of a big transformation. From a more or less closed provider system, we provide everything soup to nuts, although we sometimes buy some care in the community. And culturally, we still think of ourselves as this closed system, to transitioning to a place where we are both a system and a health plan because of the Choice Act. This is a lot of change. So the first strategy, again, speaks to operating a healthcare network that anticipates and meets the needs and the unique needs of enrolled veterans and the service-disabled and most vulnerable veterans in particular. The second strategy focuses on high-quality, veteran-centered care. Getting this right, by the way, will mean that we are going to have to crack the code, if you will, on an aspect of care delivery that I don't think anyone in healthcare has figured out yet, and that is coordination and navigation. We do pieces of it well, but I'll bet a lot of you have gotten calls from friends, colleagues, relatives, and so forth saying, you know, my mother-in-law was just discharged. We're not sure what to do next. Did we miss something? Did we forget to pick up a document? And the short answer is no. You're on your own. You get to figure it out. We are going to do better than that. The third focuses on leveraging information technologies, analytics, and models of care to optimize individual well-being and population health. Now, the great news here is, you know, right now there's a huge amount of excitement in healthcare about the so-called triple aim: better health, better health care, as well as better value. People get very excited about this, which means that there are private sector organizations everywhere saying, yep, we're all about the triple aim. But the truth is, when it comes to better health, there's a huge gap between their aspirations and what they can actually deliver, because all of us know that what really impacts health is health care to some extent, but actually the social determinants that relate to income, education, housing, and so forth. And actually, we have the opportunity to have a big impact on those determinants. The fourth strategy is to grow an organizational culture rooted in our core values and mission that prioritizes the veterans first, engaging and inspiring employees to their highest performance level, and so that we can get problems solved as close to the veteran who has the problem as possible. The fifth strategy focuses on an environment of continuous learning, responsible risk-taking, and personal accountability. You know, Mike mentioned that I used to direct the Agency for Healthcare Research and Quality. So our aspiration was to fund the development of tools, strategies, and so forth to improve the safety and quality of healthcare. And anytime it worked, we were totally, totally thrilled. And we knew we were successful when many other agencies took credit for the work. That's exactly where you want to be, right? That is a home run. But the truth is that there was always a time lag. Historically, the time lag is about 17 years from the time you start research to the time it actually benefits patient care. We can, and in many cases do, actually translate that into practice as improved care for veterans much, much faster than that, and we can still do it a lot more rapidly than we do now. The sixth strategy focuses on a model of care that's personalized, proactive, and actually patient-driven, and inspires veterans to their highest possible level of health and well-being. For the past several years, there are many parts of our system strongly engaged in literally redefining what healthcare encounters are about, that it's really about the veterans' health goals and what they want for their lives. Contrary to the opinions of some health economists, some of whom are my best friends, people really don't get up every morning lusting to have more and more encounters with the healthcare system. They really want to get that over with so they can go back to the rest of their lives. The seventh strategy is all about research and treatment of military service-related conditions. The eighth strategy leverages what I think of as one of our long-standing, most effective partnerships, and that is our affiliations with 131 of the nation's medical schools. So, you know, if you ask any group of doctors, how many of you have had some of your training at a VA, the number of hands that will go up is somewhere between 70 and 80%. That is a huge footprint on the future pipeline of healthcare professionals. The ninth is to operate and communicate with integrity, transparency, and accountability, because we recognize that we have, in many instances, lost the trust of the veterans we have the honor of serving, and we are utterly bound and determined to re-earn that trust back. And the 10th strategy focuses on modernizing management processes in human resources, payment, capital infrastructure, and so forth. So essentially, this is guiding employees along with us in rebuilding veterans' trust in the healthcare system and in those who provide their care services. We had a lot of problems last spring, for sure. We have not solved all of them. We've made some big improvements, and we've made big enhancements in waiting times and so forth, and that's all good, but we have a lot more work to do. Some of the veterans I worried about the most were people who actually thought things were pretty good. And then they heard all this noise in the media and were suddenly thinking, wow, maybe I had it all wrong. Maybe I can't even trust my own perceptions. So we're very, very focused on the trust issues. The blueprint creates high expectations for employees to actually live up to these 4 strategies. And part of that will be a focus on accountability, because you can't have a just culture where people feel very comfortable stepping up to say, we got a problem here and we need to solve it because it's getting in our way meeting veterans' needs, unless accountability is part of that picture as well. And again, it is a publicly shared organizing approach for coordinating the implementation of some of our highest guiding principles found in our strategic plans and so forth. So some of the transformational actions I'll just mention briefly. In terms of a healthcare network anticipating and meeting the needs of enrolled veterans, we have the largest footprint in the country in a patient-centered medical home. We call it patient-aligned care teams. I'm actually speaking to a large group practice affiliated with Hopkins later this evening. And when I told them that we, in addition to having rolled this out system-wide, actually monitor what's going on in terms of veteran experiences and in terms of any impact on provider burnout, we're all going to be facing challenges having enough primary care clinicians, worried about competition with the private sector, and so forth. So that's just one kind of example. Delivering high-quality veteran-centered care. We talked a little bit about the triple aim, and we are very focused on benchmarking our performance with the private sector. Now, it turns out when we look, and we've been doing this for a few years, at how we do compare with the private sector using the standard metrics that many of you are familiar with, those reported on Hospital Compare, those used by the group that accredits health plans and so forth. As a system, we actually do pretty well. In some cases, we actually exceed the private sector. In fact, in terms of veteran experience, you know, the one part of patients' perspectives on care the private sector hospitals worry about, the one item is, would you recommend this hospital to a friend or family member? Because that's where their margin is going to be for elective procedures and so forth. We knock the socks off of private sector hospitals on that one item. It's when you look below the level of the system that we realize we have inconsistencies, and that's really what we've got to be focused on. Many of our facilities have taken a deep dive into Lean as a transformative tool. Some of them are phenomenal. In fact, in our network in New England, it's part of new employee orientation. Not the full training, of course, a little lean light, if you will, but it sets the stage from literally the first day you come for orientation, that this is a part of the fabric of what we do. And if you want to get involved, you can sign up as you're finishing this orientation. And we're also realigning our performance plans internally, both for leaders and employees, so that they are very tightly linked with the results that we want to achieve. In terms of population health, we have a huge array of information technologies, analytics, all being deployed and tested to optimize individual health and well-being. For example, we actually have a way to identify those veterans with the highest burden of illness so that people can know and be proactive in terms of anticipating what's the next problem going to be, not just the one that you're going to be having here. And our huge, huge challenge, which I know many of you are struggling with, is as we transition to being both a provider system and a health plan, we have got to figure out how to bring the data back. This is probably going to be the hardest part of care coordination. We serve veterans who get all of their care from us. We serve veterans who get very little of their care from us, but they come by for hearing aids or glasses because that's a better deal than the insurance that they have. And we serve veterans who come in and out. And we also, at least in theory, serve veterans who don't come to us at all because they're feeling fine right now, and so forth. We've got to figure out how to meet and anticipate the needs of all of those. And a very, very key part of that is going to be getting the data back. So I'll just close by telling you, I know many of you have sat in meetings. Mike Cowan and I certainly have for quite a few years. Not that we started very, very young. You know, where people talk about patients' information seamlessly flowing wherever the patient goes, and it all sounds wonderful, and then you realize you're looking at a PowerPoint slide and not hearing about real life. Some of you may have heard an announcement this year where Walgreens offered free flu shots to up to 75,000 veterans. Now, that's a lovely thing to do. The flu shots is not the big innovation, though. They're important, for sure. The innovation is if a veteran gets their flu shot at Walgreens as the result of a strategic and innovative partnership, that information comes back to us because we have established a portal to make that happen. When you grasp that, you start to realize that it is true. Electrons really can follow patients seamlessly. There's a lot of work to do to make that work for other areas of healthcare, but I'm very, very optimistic about the future. So thank you very, very much for the opportunity to speak this morning. Mike, I don't know how you're doing Q&A, if you want to hold till the end, or? Do you want time for questions, or should we just? We have some time if there are questions. Okay. Questions or outright disagreements? Oh, thank you, yes.
Thank you, Dr. Clancy. My name is Carolyn Hunter. I'm with the Public Health Service, detailed to the National Guard.
Ah.
Do you have proposed timelines for objectives and strategies?
You know, that's a really great question. Do we have proposed timelines? You know, we have been in almost an emergency situation for the past 5 or 6 months, figuring out how can we get more veterans seen right now and solving problems that raised for us. And we are transitioning along with our transition that comes with the new law to a place where we actually get that kind of precision about timelines. I think one thing I know from my research life is it's very hard to say how fast you can fix a problem. What we have figured out is how to use a statistical tool to assess whether you're improving the problem. So we have a terrific tool called SAIL, which is called Strategic Analytics for Integration and Learning. And this is a tool which is a little bit like Truvin's Health Index, although to be honest, we think it's better. But it actually integrates across multiple dimensions of hospital, outpatient performance, and so forth, including veteran experience. And it rates facilities at a level of stars. And sometimes you change a star level. The stars make people uncomfortable, I'm sure for reasons you would all understand. You know, the concept that if I get better, I get more stars. If somebody else goes down, doesn't always sit well or feel terribly collaborative. But there's also a way to use that same tool to figure out, you know, by design, most facilities are going to be in the 3-star range on a scale from 1 to 5. So you can be making great improvements or actually losing ground in the 3-star range before you're going to see a change in the number of stars. This improvement index actually gives us a tool to be able to see whether things are heading in the right direction. It doesn't totally answer the time frame question, but I think it's a good down payment on it. Yes, back here.
Morning, Dr. Clancy. I'm retired from the Air Force physician 2 months ago and recently went to work for the VA in San Antonio. A lot of the initiatives that have been brought up, and you know, I get emails from you and emails from the secretary, are all very good, and there's a lot of hope among the organization that the problems in the healthcare system can be fixed. The frontline workers in the VA system, the nurses and techs and docs who are taking care of the patients, love what they're doing. They're all very competent. They are absolutely committed to taking care of the veterans. And there's a lot of frustration that their supervisors, their giant middle management system that doesn't take care of those, they're not the frontline workers, but they're the ones that are being involved in the decision making as to how we're going to restructure the VA. And I can tell you there's some frustration from those frontline workers that giant middle management layer is primarily concerned with maintaining their own status quo. And the frontline docs and nurses I have a nurse who's being told by her supervisor, you're not allowed to go do that. You're not allowed to leave the clinic and go talk to these patients up on the floor and do pre-op teaching. And I can't do anything about it because her supervisor is in charge of her and she writes her performance report and she determines whether she's going to keep her job or not. So is there some way that big organizational VA can do a better job of integrating the concerns of those frontline workers in that inverted pyramid system, the people who are actually delivering the care to the veterans, and incorporate that into, because they'll tell you, they're like, I know how to fix this today. This doesn't require a giant commission. This is a very simple thing, but it's going to, you know, my supervisor isn't going to like it because it's going to take the power out of her hands. Is there some way that we can empower those frontline people to fix the system?
Really, really great question. And I think a very, very aptly described reflection of what often happens on the ground. I'm sure that you're well aware that as a result of our crisis and questions about the integrity of our data, about measuring performance, how long people were waiting, and so forth, we're not holding people accountable for that, right? That's not part of anyone's performance plan. There's only one little challenge. What that doesn't do, it doesn't give people a new way to be. and supervise. So training is going to be a huge, huge part of this. I have to say, I have been chagrined and disappointed to learn how much responsibility a lot of these frontline folks have. I'm talking about the people who are directly interfacing with the veterans, and they are our most important asset if you think about it, and they have very, very, very low grades in the civil service system. So we have figured out a way to improve that for some of them, particularly those who are part of the PAC teams, but it's going to take a lot of training. And in some cases, it's probably going to take helping people move on to other job opportunities if they can't actually adjust to a new way of being. You know, many years ago, I was part of a group where they actually, this was pretty radical about 20 years ago. It was an effort focused on primary care research, and someone had the brilliant idea, which is becoming increasingly commonplace, of bringing in a focus group of patients. So, you know, understand these are all research egghead types, right? There to come up with grand hypotheses, and here we are listening to real people. But when asked who had the most power in their lives about primary care, you better believe not one of them said a doctor, nurse, or anything else. They basically said the person who's got the schedule and answers the phone. Both areas where we need a lot of work to help them work seamlessly as a team. And that will include, I think, learning from those sites that actually do a good job. Even if we're not sure why they got there, you know, this is a strategy that's often used in public health, the so-called positive deviance approach. But I think those are all the ideas that we're going to need to do. And for those of you who are familiar with the principles of lean, one of the best examples I know is the Denver health system. This is not a system that's richly resourced. It's a public hospital and outpatient clinics and a small HMO, and they provide services for prisoners and so forth, and a lot of uninsured people, many, many languages spoken by their patients. And this is a pretty challenged system, and yet they have transformed utterly. And when I asked the woman who had directed this and led this transformation, she was there for well over 20 years, how did you do that? She just said, relentless focus. And it will take that for us as well. Yes, last question.
Dr. Clancy, Fred Hannett with Capital Alliance. Thank you so much for being here. Quick question about your comment about bringing the data back. I know that you're utilizing the PC3, or Patient-Centered Community Care Program, to implement the Access Bill, or the Choice Act. What's been your experience there in terms of interoperability, and do you see that as that program as a potential laboratory or test for using new forms of interoperability to bring data back?
So I'm going to gloss over astonishing amounts of really, really hard work to say any place where we've got well-defined standards, laboratory tests, medications, and so forth, it should be relatively straightforward to get the data back. Mike Cowan and I have had a conversation before about, you know, many people think that if you see a patient for the first time, you need everything about them. I mean, literally everything. And yet when you get right down to it, a few key pieces of information would be such a huge quantum leap from having nothing that makes a very large difference, even in an emergency situation. So I think clearly we can expect the initial strides to come in areas where we've already got well-established standards and so forth. Obviously, the Office of the National Coordinator for Health IT is pushing this hard. First initial steps as part of Meaningful Use Stage 2 and so forth. And to be honest, we could do our part flawlessly, but this is very much interdependent with what's going on in the private sector where people are getting care out in the community. So I don't mean to make this sound too easy or to suggest that I think there's nothing to this, but I do think that we can be a very positive force for being part of the solution. So I'll stop there. Great.